And there we go. So it's a pleasure to come back again and talk about a favorite topic for me, the chronic total occlusion PCI. And Fadi asked me to put the program of this morning session that we put, and we thanks Dr. Galassi for being here to participate to this session today. I will start by talking about the step-by-step that you need to follow for a CTO PCI case. The case selection by itself, the angio evaluation, and the management of complications. And in the coming topics, we will be talking about the retrograde, about the antegrade approach, step by step that you need to progress through, and the hybrid approach, because this is a movable target CTO PCIs. First of all, what's the prevalence of CTO? Dr. Strauss in Toronto did a great job looking for 14,500 coronary angiograms that was performed in the cath lab in Toronto, and then they looked for the prevalence of CTOs, excluding CABG patients, excluding STEMI patients, and looking to the patients that will come for non-ST, ACS, and stable angina and other indications. And then you can see that the prevalence of CTOs is 18%. So this is almost one patient over 5 that you would perform a coronary angiogram on them, they will have a CTO. 2/3 of them, they will have a single vessel CTO, and 1/3 of them will have a more than one vessel CTO. So this is highly prevalent. Do we need to touch all those CTOs? The answer is no. You do as you do for your non-CTO PCIs. You look for the symptoms of the patient, the quality of life of the patient, the functional status of your patient. You look to the ejection fraction. If you have an ischemic cardiomyopathy, that opening that CTO will improve the LV function, and of course for survival when you have a high ischemic burden. People don't know why they have angina when they come to see you. You know. Myocardial oxygen demand outstrips the myocardial oxygen delivery. Myocytes don't know the cause of the hypoxic status where they are. Only you, when you look to the angiogram, you determine why this patient is ischemic, why the myocytes are suffering from ischemia. You need to treat the patient based on the angio findings, not only what you can do, what the patient needs. This is why you refer some patients for CABG, because you think that the CABG is the best solution for this patient to treat based on the anatomical and ischemic status of this patient. And we know from a lot of trials, and this meta-analysis will show us, the better complete revascularization we give to our patients, the better is the outcome, with a reduction by 29% on the cardiac mortality, on the total mortality, reduction on the MIs, reduction on the need of revascularization. And of course, the surgeons are doing a better job than we are doing to complete revascularization. You can see 25% of incomplete revascularization in patients treated with CABG, and it's up to 56%. So this is one patient over 2 that you perform a PCI on them, will leave them without complete revascularization that will impact hard endpoints, as you can see here. And one of the major reasons for incomplete revascularization is chronic total occlusion. You can see in the Acuity trial, we looked on the untreated lesions, and you can see CTOs when you have a residual syntax score higher than 8. So you complete the PCI and you calculate the residual syntax score. You have a residual syntax score higher than 8. This will impact mortality and myocardial infarction in the 5 years of follow-up. And the main reasons for having a high residual syntax score, 43% of cases, chronic total occlusion. So that Dr. Galassi put in this nice paper in European Heart Journal, how we proceed to pick up the patients that needs to be revascularized having a CTO. First of all, the symptoms. If the patient is suffering from any angina, despite medical therapy, you look to the LV. If you have a normal LV, you have a normal viability. Angina by itself is equivalent to ischemia. Then you go and you perform the CTO. If the patient do not have angina, then you look to the LV function, you look to the viability. If there is no viability, it's a scar, there is no need to touch that vessel. If you have a viability, which means that the wall motion is still normal or hypokinetic, then you look to the ischemic burden. If you have a high ischemic burden, you have the possibility to have a nuclear test that would tell you 10% or more of that LV is ischemic. Then we know from the nuclear substudy of the COURAGE studies that you may impact the mortality and MI rates in the 5 years of follow-up on those patients, and that this patient will deserve to perform a CTO PCI on them. In our practice, we have a realistic discussion with the patient regarding the benefits, regarding the risk of the procedure by itself. CTO PCI is indicated in the setting of persistent symptoms despite best tolerated medical therapy. And yes, we do some CTO PCIs in asymptomatic patients if they have a high ischemic burden, and if we think that the PCI will improve the ejection fraction on these patients, will keep them away from the need of a VAD or send them for a transplantation, or the need for a defibrillator. If they have an ejection fraction close to 35%, let's say, for primary prevention defibrillator, and they have a CTO of a big dominant left circumflex or RCA or LAD with a proven ischemia, we will open the CTO vessel, reassess in a couple of months the LV function, and then determine if the patient will remain low to 35 or less and go for the defibrillator. If you look to the open CTO registry in the States and you look what was the main reason for opening the CTOs, it was for symptom reliefs. As you can see, 72% of patients, the CTO was treated because of persistent symptoms, and that was the main reason. The opposite side, if you look, if that was done in an inappropriate way, and then you can see it's only in the minority of cases, 3% of cases, that was rarely appropriate to perform that CTO. To perform the CTO, you need to have a special mindset. You need to change your rules, the rules of the game that you will perform. You cannot ask a driver of this small jet to drive a F-16 plane. It's a different mindset, it's a different training, it's a different preparations that you need to have. And you cannot be only an integrate CTO operators. Yes, you may succeed maybe 50-60% by a wire escalation technique, the integrate, but if you are stuck there, you need to take a plan B, a plan C. And plan B and plan C could be dissection re-entry, could be retrograde, and we will see during the morning session that how we can switch from one approach to another approach, and this is the beauty of the hybrid approach that we will be discussing later. First of all, you need to sit to look to the diagnostic angio. Here in your setting, I know that you do not perform a lot of ad hoc PCIs, which is good for those cases because you need to study the angio. In other, maybe European or North American practice, there is a lot of ad hoc PCIs that we perform because of the volume in the cath labs. CTO PCI is never an ad hoc PCI, never ever. You need to sit to assess the feasibility and the technical difficulty of the coming CTO PCI to gain as much as you can knowledge about the game plan that you will put for the procedure, and you should spend 15-20 minutes looking to the collaterals, looking to the ambiguity of the proximal cap, looking to the distal bed. All those points we'll discuss it later. I tell my patients that I know your heart by heart. I look to the angio, I look to the collaterals, I look to the vessels, I look to the plan A, plan B, and plan C. And this is a Japanese CTO score. This score will determine the rapidity of the success of the procedure within 30 minutes of you will cross or not. And as you can see here, there is 5 points that will give you a final score. The highest is your score, the more complex is your CTO, and then you need to prepare to succeed that CTO. You score for a previously failed lesion, blunt stump, bending, calcification, and a total occlusion length higher than 20 millimeters. Those points are putting all together. Brigalis published the hybrid algorithm and the JAC in 2012. The most important part, and we see it a lot, based on the diagnostic angio, you think that this CTO is a 40 millimeter length CTO. You do a dual injection, and then you see that that CTO is maybe 15 or 20 millimeters of length. So dual injection is a base. You cannot perform a CTO PCI without having a dual access unless all your collaterals are from the same side, but usually majority of cases you have contralateral collaterals. And the first thing you look to is if your proximal cap is ambiguous or not. You look to the distal target, if you have a good or poor distal target, and if you have an appropriate interventional collaterals. If you have any of those points, then you should start doing a retrograde. Retrograde could be true to true. You go from a true lumen to a true lumen. If you don't have, you cannot do go through to true, then you go dissection and re-entry. You do your reverse cart and reassess the true lumen, regain the true lumen before the proximal cap. If you don't have any of those lines, then you can go integrate, mainly if you have a lesion length less than 20 millimeters, and it could be a integrate escalating wire escalation, or it could be an integrate dissection re-entry, either wire-based, the last technique, or using the Stingray technology. What is important to know, if you go in one way in this algorithm, you are not stuck to continue on that way. Maybe I will start with an antigrade wiring technique and I will fail to regain the true lumen using the antigrade wiring technique. It's not the end of the procedure. I can switch to go for an antigrade dissection reentry technique. I can go for a retrograde. I fail the retrograde. I come back to do a dissection reentry technique. This is a movable target. You are not stuck in a tunnel that you need to continue in the same way. If it's not working with this approach, move to another approach. Don't spend a lot of time giving radiation, giving contracts to be tired by 2 hours of working just hitting one approach. Move from one approach to the other one. Why it's important to assess the proximal cap? Because it determines the suitability of an antigrade approach, the likelihood of success, and the risk of the procedure. Ask yourself, where is the proximal cap? What does it look like? Is it blunt? Is it tapered? Is there an important side branch? Can I get something going antigrade, going down antigrade? Pay attention to the pseudo-ambiguity, and this is mainly related to suboptimal angiogram that you will have initially. What you can do, you can take multiple angles, you can evaluate the guide support, the tortuosity, and the calcification to guide you. Why it's important? It's important because it will impact the strategies that you will use to succeed the CTO PCI. We know when we have an ambiguous cap, then you have a higher rate of retrograde. We know that retrograde is associated with a bit of higher rate of MACE complications. So it will impact the outcome of the procedure, and it will impact the success of the PCI by itself. When you do not have a non-ambiguous cap, your success rate can go up to 90%, 93%, and it's a bit less, going down to 85% when you have an ambiguous proximal cap. You need to look to the distal vessel. It determines the suitability of an antigrade approach dissection reentry. If you have a good distal target, then you can re-enter if you go suboptimal. So what is the distal vessel caliber? Is it a 1.5 small branch? Then the probability of putting dissection reentry materials there and having a good success rate is less. Is there a bifurcation? May I lose one branch if I go dissection reentry there? Is there a lot of calcifications that I will try to avoid and go a bit further to re-enter and gain the true lumen? Take a good contralateral injection with a long cine to assess the distal bed. Collateral evaluation, I guess Dr. Galassi will be talking about that because it's a main approach for retrograde. Do they get there? Where they will get? How much I will be from my distal cap? Are they tortuous? Are they frequent? If I lose this collateral, it will impact the ischemic burden of that patient. I may lose visibility. All those questions you need to ask them to look on that before you start the procedure. Find the right angle. Don't pan when you are doing the angiogram because you need to follow those collaterals and don't be too deterministic. The optimal projections for septal collaterals, RAO cranial, RAO straight. Septal collateral pathways are determined there. Collateral exit and entry angles, you can see them there. If you want to look for the septal tortuosity and you look to the distal RCA bifurcation and some epicardial collaterals going from the left circumflex and the AV groove to the posterolaterals, then the LAO cranial is a good angulation that you need to have. The antriangulation, if you look to the right panel there, if you have a wide open angle, then it's very easy to get to the septal. If you have a 90-degree septal takeoff, then it's more hard to wire it and more hard to get in, and the more distal is your septal collaterals that you may take, the more complex is the procedure. If you have extremely tortuous collaterals, as you can see on the left lower panel, this is epicardial collaterals that we try to do not navigate those through those collaterals. We may take the other epicardial collaterals going from the distal LAD to the RCA. It's almost a side branch caliber. It's less tortuous and it's more easy to navigate through that collateral. Lesion lengths, it helps to determine the difficulty and primary approach. How long is the lesion? Do I have multiple CTOs? And of course, the dual injection will help you to determine the lesion length. The lesion length higher than 20 millimeters will increase the complexity of the procedure. It's assigned as a point in 2 of the 3 available CTO scoring systems. Dual angiography correctly estimate the lesion length. And in both antigrades and retrograde cases, longer the lesion is, the more likely that you may need dissection and re-entry. You have now your plan, you look to the basic angio, you need to have the materials in your CAT labs before you move to the labs. This is a CTO card we have, and all our devices related to CTO procedures are there. The technicians will not run to the right and to the left to bring the materials while you need it. This car is in the CAT lab. We move it to the CAT lab when you start a CTO case. It will include dedicated guidings, the Y connectors, extension catheters, CTO wires, micro catheters, re-entry systems, and lassos. Guiding catheters, you can go 6 or 8 French, depending on your comfort, depending on your experience. We usually go with a 6 French. We use the extra backup for the left. We use left implants, as I showed you. We discussed it yesterday. And more than the right Jodkins. We use short guiding catheters, 90 centimeters, if we think we will go retrograde, because it will give us a more quicker and easier wire externalization in the retrogrades. Y connectors, we use more Y connectors with hemostatic valves as a co-pilot from Abbott Vascular, because it will reduce the amount of blood you will lose in long procedure and facilitate the device exchanges. Extension catheters, we have 2 of them. We have the guideliner, which does exist in 6 and 8 French, 25 centimeter extension diameter. We have the Guidezilla from Boston, 6 French, 25 centimeters also. And recently we have the trap liner. We talked yesterday about the trapping technique. Here you have the beauty that you have your guideliner, and inside the guideliner, as you can see up, there is a balloon that you will inflate. There is no need to put a balloon aside your micro catheter because it will not fit in the 6 French. And then you inflate that balloon and you preserve your distal wire position. The extension is only 13 centimeters. The wires, we have a dedicated talk yesterday about the guide wires, workhorse wire to get to the proximal cap, collateral wires, the Cheyenne, the Cheyenne Blue, the Fielder XT, and the Pilot 200 XTA or XTR. They are polymeric hydrophilic wires. We use them in the wire escalation technique. The Gaia family did improve our antegrade success rate. They are CTO wires navigators, and the piercers such as the Confianza or the Hornet 14 grams, and externalization wires, the RG3 and the R350. Microcatheters, they are crucial. It's useless to advance a wire without a microcatheter when you start a CTO. They are crucial because they will increase the wire support. They will allow rapid and safe guide wire exchanges. If you go subintimal, you have a hematoma, you can aspirate by those microcatheters. If you have a distal tip perforation, you can deploy a negative pressure that will prevent bleeding from that distal perforation until you treat it. Mainly for retrograde approach, the Corsair is a collateral dilators. It's a tapered tip. You go 5 to 10 rotations on one side, 5 to 10 rotations on the other sides. You can use it mainly in septals. You can use it also in epicardial collaterals. The microcatheters we usually use mainly in the antegrade technique are the fine cross or the turnpike LP. We have also the turnpike spiral, and we have the caravel that we use also in dedicated cases. This is a re-entry system. The crossbus catheter with as you can see, it's atraumatic distal tip, olive-like, and you have the Stingray balloon that you position in your subintimal space, and you stick using the Stingray wire to regain the true lumen. If you are using retrograde and your wire get into the aorta, you need to snare it. We use large loops, 18-30 millimeters, and EN snare to snare the wire and bring it to the antegrade system, externalize it. Balloon uncrossable lesions, there is an algorithm for that, but the Tornus could be helpful. We mainly use the 2.6 French. As you know, you advance it counterclocks up to 20 times. Twin pass, as the case that I showed yesterday, we can use it to re-enter using another wire. We can use it to access a side branch. It's very practical. Now you have the materials. You need to look to the arterial axis that you may use. Radial artery is similar to femoral artery in terms of success and safety. You can, as you can see here, it gives you the same technical success, procedural success, and the same rate of complication in your CTOs. The more access you have, the higher rate of success you may have. You can use, of course, bilateral femoral. You can use bilateral radial. You can use left radial, right femoral. We usually use right radial, right femoral. We put the femoral in the CTO artery and the right radial in the contralateral artery. Majority of CTOs, you need at least 2 2 axes. In some post-CABG patient, you may need 3 axes, one in the lima, one in the donor artery, one in the left system. When bilateral femoral axis is preferred as compared to the radial artery, if you do not have a radial artery, patent rated artery, if you have a rated artery that cannot accommodate 6 French guiding catheter, very small, if you have anatomic variation or significant tortuosity, if you need or will need permanent hemodialysis, then you preserve the radial artery. And if you get a previous failure with a radial artery because you do not have enough support, then you do not restart there. Otherwise, you can go bilateral. You can a radial artery. We can use it in the majority of CTO cases, mainly if the patient have a significant peripheral arterial disease, the patient with high risk for bleeding from femoral axis, need for hemodynamic support. You preserve the femoral axis. If you go biradial, you use the left radial artery for the right coronary artery to engage the right coronary artery, and your right radial artery to engage the left coronary artery. You can almost do everything using the 6 French system, except having an IVUS catheter with a micro catheter. You need to go up to 8 French, and you cannot trap the wire if you are using a Tornis or the cross-boss Stingray system. You need an 8 French, otherwise you can do wherever you want using the 6 French. I will finish with the complications. Complications could be either cardiac or extracardiac. Cardiac could be related to a non-coronary complication such as myocardial infarction, periprocedural MI, or aortic dissection, or coronary that could be mainly related to perforations. Extracardiacs, radiation, you need to think about it, vascular complications, and contrast-induced nephropathy. Of course, you need to consent your patient, and the consent of your patient should be based on the operator experience. The more is your experience, the higher is your success rate, the lower is your rate of complications. There is a minimum of 50 CTOs that you need to perform in a year to maintain your technical skills, to improve your success rate. Dr. Garassi is the founder of the European CTO registry, and here you can see the rate of procedural success. It's of course higher by European operators using the antegrade as compared to the retrograde. And you can see here the rate of complication. General complications are usually of low rates. There is no significance between the retrograde and the antegrade. What is more higher in the retrograde approach is the rate of donor vessel dissection and coronary artery perforation. And this is the same thing that we saw in the States in the Progress CTO group data. They have a higher success rate using the antegrade than the retrograde, with a higher procedural success rate in the antegrade as compared to the retrograde. And when you look to the MACE rate, you have a higher rate of complications, higher rate of myocardial infarction by losing collaterals, mainly using the retrograde as compared to the antegrade. Why we have higher myocardial infarction? Because we may lose ipsilateral or contralateral collaterals. You may have a donor vessel thrombosis, spasm, or occlusion. Dissection, you may have extensive subintimal hematoma that will progress to your distal bed. You may lose side branches. You may embolize air. You may embolize thrombus. You need to pay attention to all that. This is a case of a spasm in the donor artery manipulating to get into a distal septal. The LAD closed. It was only spasm. We give intracoronary nitro, and as you can see, the LAD restored a normal flow afterwards. This is a case of a proximal LAD CTOs after we finished the procedure, taking a shot, donor artery dissection induced by the distal tip position of the right coronary artery that we had to treat by a stenting of the proximal RCA to restore a normal flow. Perforation, it could be the vessel by itself because you went out from the vessel architecture, or you oversize the diameter of your devices, or it could be related to perforations on your septals or the epicardial collaterals, or distal tip wires perforation. So how to treat them? Prolonged balloon inflation. You can put a covered stand. The Papyrus from the Biotronics, they are really good stands with a great profile. You can use the pinpoint technique to keep an occlusive balloon to prevent the bleeding in the pericardium space. You can use coils. I showed you yesterday the case of the gel foam we used. You need to have an echo to assess the amount of blood in the pericardium, and perform pericardiocentesis as needed clinically. So this is a case of a right coronary artery CTO here, antegrade wire escalation. We succeeded to open that coronary artery. doing a post-dilatation, you can see a perforation, type 3 perforation in the mid part of the RCA that requested a covered stent to treat that perforation. Septal collaterals perforation are a complication of the retrograde approach. Usually there is no specific treatment for that. If it's going to the right ventricle cavity, as in the majority of cases, it's related to an extraluminal passage from the septal collaterals, or if you go rough with the septals with your microcatheters or doing balloon dilatation. So this is a case of proximal LAD CTO here that we succeeded to go on a retrograde reverse card, and we succeeded to go down with a regular wires, and you can see at the end of the procedure the septal branch we used did perforate it. It's leaking to the right ventricle without any consequences. We leave it as it is. Epicardial collaterals, this is a more serious complication. It will give you immediately a tamponade. It's less likely to occur in open-chested patients, should only be attempted in very experienced CTO operators, and it's usually caused by aggressive wires or microcatheters manipulation, so no surfing in the epicardial collaterals and no balloon dilatations. It requires immediate correction, the epicardial collateral using a negative pressure at that wedge tip of your microcatheter, and you can coil it, you can put gel foam, you can put fat there to coil it, and you need to coil it from both sides. You need to coil it from the antegrade and from the retrograde approach, get a final bilateral angiography, and use echo contrast to be sure that there is no contrast still leaking to the pericardium space. Otherwise, the patients may get into tamponade again. Distal wires, they occur usually when guide wire, usually stiff, or polymer jacketed wire or microcatheter will go in very tiny branches. It's more a antegrade cases complication. When you get to the distal bed, you are in the true lumen. Always switch CTO wires to a workhorse wire to prevent distal tip perforation. You can use a prolonged over the wire or microcatheter suction technique, and in majority of cases, you may need to embolize the distal tip of those branches to prevent continuous bleeding. Equipment entrapment or loss, it's more common complications in tortuous and calcified vessel. It's complications that could be related to catheter tip mating of a retrograde with an antegrade balloon or stent, excessive rotation of guide wires when you are in the subintimal space. And when you are removing you should not neglect the power you have when you externalize a wire, when you are pushing materials through tortuous and calcified vessels. We use regular techniques. We use small balloons. You open that balloon and you try to take everything out. You may snare, or you may need to crush the embolized material with a stent to the coronary wall. Non-cardiac complications, I will end with that. Aortic dissection, so it's mainly related to aggressive guide manipulations. Left amplats, you need to be aware of the secondary curves that you will use. It's more frequent in the right coronary artery if you oversize your ostial balloons or stents. And when you are removing externalized materials, you need to pay attention to the donor artery guides that may engage deeply in the artery when you are pulling out the externalized material. So you need to keep an eye on that and keep your guiding catheter out in the aorta. Few words on the contrast-induced nephropathy. You need to calculate the maximum recommended contrast dose that you can use prior to the CTO. It's equal to 5 cc of contrast by the body weight of patient in kilogram divided in the serum creatinine. You can check the LVEDP of your patient at the beginning of the procedure to know if it is too low, then you can hydrate, and we know hydration is the best treatment for contrast nephropathy. And you can consider aborting the procedure if you are not getting that and you lose a lot of contrast and you are beyond the MRCD. We had a nice topic regarding the radiation. We usually work using the 7.5 frames per second. The radiology technician in the cath labs will give us every 30 minutes how much gray we get up till now. We terminate the procedure if we will not succeed to have a wire in a true lumen and that we are up to 5 grays. Patient education is key. As we learned yesterday, you need to inform your patient when they will have any symptoms, dermatological symptoms, they need to come back to see you. Don't go to the GP, don't go to other doctor, to the dermatology, because they will not, link those symptoms and those signs to the procedure. I will not think of radiation dermatitis. And the bad thing that may do is to get a biopsy from that dermatitis, and it will lead to necrosis there. Usually, if we go up to 5-6 grades, we can consider reattempting 2 to 3 months after the procedure if there is no signs of radiation dermatitis, and there is more and more special pads that you can use that will prevent from radiation for the operators also. So final words from the conclusion: plan, plan, and plan. Don't start this procedure without having a plan A, plan B, and plan C. Works in pairs if possible. As you know, proctors does exist to start your programs to help you start succeeding those cases. PCI consent should detail the CTO specific risk, and have a CTO card ready with several required devices will help you to improve the success of the procedures. Thank you very much for your attention.